This is the second talk about median nerve. It is intended for the neurophysiology fellows at Nicklaus Children's Hospital. It will be conducted in a question and answer format. The first question: median nerve carpal tunnel lesions tend to occur close to the outlet of the carpal tunnel canal. A true, B false. This figure is a representation of the median nerve and related hand structures. In it, you can see the flexor carpi radialis tendon, the palmaris longus tendon, the distal wrist crease, the distal palmar crease, the median nerve, the palmar cutaneous branch of the median nerve, the flexor retinaculum, also called the transverse carpal tunnel, the recurrent branch of the median nerve, the motor branches of the median nerve for the first two lumbricals, and the digital cutaneous branches of the median nerve. In this frame, I have added the red burst sign at the most common site of median nerve compression in patients with carpal tunnel syndrome. So the answer to this question is A. Next question. The median nerve branch that innervates the abductor pollicis brevis is called the hypothenar branch. A true, B false. This is the same figure I just used to answer the last question. I have now labeled the abductor pollicis brevis. This muscle is innervated by the recurrent branch of the median nerve. So the answer to this question is B. Next question. The split hand syndrome of amyotrophic lateral sclerosis can be explained by A. ulnar involvement, B. median nerve involvement, C. C8 radiculopathy, D. none of the above. Notice the distribution of the atrophy in this patient's hand. The atrophy involves the first dorsal interosseous and the thenar muscles, and it spares the hypothenar muscles. This pattern of neurological deficit affecting the radial side of the hand cannot be explained by a lesion in the peripheral nervous system once anomalous innervation have been eliminated by electrodiagnostic testing. Thus, we must take it to indicate, particularly in patients with amyotrophic lateral sclerosis, central nervous system involvement. This frame shows a figure that was used to explain why patients like the one I just showed you had a pattern of atrophy that was consistent with central lesion. It is rather complicated and busy, but I will start telling you about it from the very beginning, and you will see that it's not that bad. I will start by telling you about cortical representation. Here you can see the cortical representation of the homunculus in a normal individual. As you can see, the thumb and the index finger representation is rather extensive. That is, the radial side of the hand has a larger representation than the representation of the ulnar side of the hand. The cortical representation of the homunculus in a patient with amyotrophic lateral sclerosis has been mapped, and according to some authors, the representation of the radial side of the hand is smaller than the representation of the ulnar side of the hand. Notice in the amyotrophic lateral sclerosis side, the small representation of the thumb and index finger in relation to the ulnar side of the hand, indicated by the red circle. The theory regarding the strange phenomena of the split hand syndrome in patients with amyotrophic lateral sclerosis is that the increased use of the pincer grasp over any other type of hand movements renders the thumb and the index finger in patients with amyotrophic lateral sclerosis exclusively vulnerable to the disease process, and as a consequence, the cortical representation of the thenar region is decreased. This theoretical explanation is supported, as we will see in the next few frames, by the inversion of the usual relation between the thenar muscle potentials triggered by peripheral nerve stimulation and the thenar muscle potential triggered by transcortical magnetic stimulation in patients with amyotrophic lateral sclerosis. Now, let's look at the cortical motor neurons and compare normal controls to patients with amyotrophic lateral sclerosis. The neuron I have just added represent neurons contributing to the innervation of the hypothenar region of the normal individual. Notice the color of the nucleus. And the arrow I have just introduced points to the area it is representing in the cortex. Now I have added cortical motor neurons concerned with movements of the radial side of the hand. As I have indicated by the parentheses on top of the neurons and in the cortex. I will now do the same on the side of the figure representing amyotrophic lateral sclerosis. As you can see, on the side of the amyotrophic lateral sclerosis, I have represented the neurons that innervate the hypothenar region by a single neuron, as I did in the normal side. And now I have done the same for the radial side of the hand. But notice that two neurons in the middle, are represented with black nuclei, and that the lines going down are interrupted. I have done this to indicate malfunctioning of these neurons. I am now introducing in the figure the lower motor neuron, that is the anterior horn motor neuron from C8 to T1 going to the hand. First in the normal side, and now on the amyotrophic lateral sclerosis side. Notice that by virtue of the abnormal innervation of the anterior horn cells by the cortical motor neurons, those lower motor neurons for the radial innervation of the hand are represented by broken lines. I will now indicate those being conveyed to the muscle by the ulnar and median nerves. Remember that an anomalous innervation such as Martin-Gruber syndrome has been deemed not present in these cases. So those axons traveling in the ulnar nerve I have represented by being encircled in an aqua circle, as you can see, and those traveling in the median nerve, which I have represented by encircling them in a magenta circle in the normal and now in the abnormal side, which, as you can see, I'm basically repeating the same on the amyotrophic lateral sclerosis side. First, I have encircled those traveling with the ulnar nerve, and now those with the median nerve. At this point, I will represent the muscles and the muscles group being innervated by these nerves in the hand. So, innervated by the ulnar nerve, you have the hypothenar muscles and the first dorsal interosseous. For the purpose of simplicity, in the diagram I will not include the adductor pollicis, nor will I include the deep head of the flexor pollicis brevis. Now, if you turn your eye towards the thinner side, you can see that I have represented the bulk of the muscles innervated by the median side in this frame. Now, going to the amyotrophic lateral sclerosis side, I will represent the muscles using the same parameters. You can see the hypothenar muscles and the atrophic first dorsal interosseous, which I have represented by adding black squares to the muscle, and the thinner muscles that are also atrophic. I will now introduce the results of compound motor action potential following hypothenar and thinner recording, which is the main reason I have shown you this chart. In the normal side, you can see that the compound muscle action potential from the hypothenar region triggered by ulnar stimulation. Now, the magnetic evoked potential from cortical stimulation, which you can see in this new frame. So the one on top is the one obtained from ulnar nerve stimulation, and the one below is the one that is obtained from magnetic cranial stimulation. Notice that the wave brought about by peripheral nerve stimulation of the ulnar nerve produced a bigger compound motor action potential than the potential triggered by magnetic stimulation of the cortex. I have now introduced the thinner muscle compound muscle action potential triggered by median nerve stimulation. And now the corresponding cortical potential, that is, the compound muscle action potential produced by magnetic stimulation of the cortex. Notice that in the thinner muscles, the cortical representation corresponding to the magnetic stimulation is larger than the compound muscle action potential triggered by nerve stimulation. Now let's turn our attention to the hypothenar region of the amyotrophic lateral sclerosis side. In the hypothenar region of patients with amyotrophic lateral sclerosis, the compound muscle action potential is higher than the potential brought about by cortical stimulation, as it was in the normal side. Now let's look at the thinner eminence. Notice that the size of the compound muscle action potential triggered by nerve stimulation and the size of the compound muscle action potential triggered by cortical stimulation. Following median nerve stimulation, the compound muscle action potential is much larger than the potential obtained following cortical stimulation. Compare the thinner eminence recording in the normal individual, which I have enclosed in a pink square, to the potential obtained in the patient with amyotrophic lateral sclerosis, which I also have enclosed in a pink square. As you can see, in the normal individual, the thinner cortical potential is larger than the peripheral generated potential. Whereas in patients with amyotrophic lateral sclerosis, it is the opposite. The peripheral trigger potential is larger than the cortical trigger potential. These findings have been interpreted to indicate a smaller or at least a less functional central area of thinner muscle representation in patients with amyotrophic lateral sclerosis. And also it has been interpreted to represent or to indicate a central origin for the split hand syndrome found in some patients with amyotrophic lateral sclerosis. I have introduced the photograph of the patient with the split hand syndrome again to show you the atrophy of the first dorsal interosseous and the thinner muscles, and the sparing of the hypothenar muscle found in this patient. In this new picture, you can see the photograph of a patient with C8 radiculopathy, that is, of the hand of a patient with C8 radiculopathy. Here, the atrophy involves the first dorsal interosseous and the hypothenar muscles. In C8 radiculopathy, the extensor indicis proprius, a radial innervated muscle, and the flexor pollicis longus, a median innervated muscle, are also affected, but the abductor pollicis brevis is either not affected or minimally affected. So the answer to this question is D. Next question. The time it takes for an stimulus to travel from the palm to the abductor pollicis brevis muscle is called the median nerve terminal motor latency by most neurologists. A true, B false. In Kimura's book, the term terminal motor latency is considered not the preferred term to indicate electrode position, and the glossary sends you to the term distal motor latency. The definition for distal motor latency is the interval between the delivery of a stimulus to the most distal point of a stimulation on a nerve and the onset of a response. Others define the term terminal latency as the time it takes for stimulus generated at the most distal customary site of a stimulation of a nerve to reach the recording electrode. The problem with this definition is the word customary. Most neurologists I have worked with use the term terminal or distal motor latency to imply the latency following a stimulation with the cathode above the wrist when it comes to median nerve testing. Recording from the motor point of the abductor pollicis brevis. That is, when the stimulation is, as you can see in this frame, with the cathode above the wrist and the recording electrode on the abductor pollicis brevis. Reference is usually placed over the abductor pollicis tendon close to the thumb, and the ground electrode must place it in the palm. As you know, the polarizing current under the cathode. Here I have introduced the potential recorded after such a stimulation with the designated recording parameters. The terminal motor latency, abbreviated TML, is the time it takes for the electrical activity to go from the cathode to the E1 electrode. The normal terminal latency in cases of median nerve in adult is less than 4 milliseconds. But as it is customary among neurophysiologists, the term has been used in different ways as I explained at the beginning of this question. This article, when referring to terminal latency, refers to wrist stimulation, as we previously discussed. Look at the words I have highlighted in green. Yet other authors use the term distal latency with a different meaning. They use it to refer to all recording going from a point of stimulation to E1 directly. This frame shows such a usage. Here, the term distal latency is used when recording from wrist to abductor pollicis brevis, and also when recording is being done from the elbow. That is, when a stimulation is being done at the elbow and still the recording is being done at the abductor pollicis brevis. This is a highly confusing terminology which, in my humble opinion, should not be used. Preston's book uses the term distal and proximal latency in the way that you can perceive in this frame. Further confusion arises when median nerve is tested in the palm, because if distal or terminal latency is defined as the interval between the delivery of a stimulus to the most distal point of a stimulation of a nerve and the onset of a response, then palmar stimulation would become the terminal or distal latency, and current normal values for it would be totally different than the ones that we use at the moment. Yet for now, and during the course of this talk, median nerve terminal latency will be defined from the above wrist stimulation to the abductor pollicis brevis. So the answer to this question is false. Next question. The tests for the evaluation of carpal tunnel syndrome consist of dash testing: A, standard; B, comparison; C, targeted; D, all of the above. Carpal tunnel syndrome can be classified as uncomplicated when no other condition is being considered. In such cases, standard testing, which we will list in a few minutes, and comparison testing are all that is necessary to confirm the diagnosis of this syndrome. Yet, if the results of comparison testing or standard testing is borderline, most neurologists I know will use the combined sensory index to establish the electrodiagnostic presence or absence of carpal tunnel syndrome. Remember, normal neurodiagnostic testing does not rule out carpal tunnel syndrome because carpal tunnel syndrome is a clinical diagnosis. When carpal tunnel syndrome is complicated, implying when other diseases are clinically suspected in addition or as an alternative diagnosis for the patient's symptoms, standard testing, comparison testing, and targeted testing tailored to the disease being considered are often required. So the answer to this question is D. Next question. Median nerve carpal tunnel syndrome comparison testing includes comparison with A, radial nerve; B, ulnar nerve; C, median nerve at the forearm; D, all of the above. Conduction of the median nerve to the carpal tunnel can be compared with median nerve conduction in the forearm, with median nerve conduction from the palm to finger region, and with other nerves in the arm and hand that do not go through the carpal tunnel. The comparison between median nerve forearm conduction and the across the wrist median nerve conduction is obtained by determining the terminal index ratio, the residual latency, or both. In the palm, we can simply compare the conduction across the wrist, that is the conduction of the median nerve in the area bracketed in this figure, to the conduction of the median nerve from the palm to finger area, where I have placed the new bracket. Again, we are comparing median nerve conduction across the wrist with median nerve conduction from the palm to the middle finger in this frame. Comparison testing can also be made with other upper extremity nerves in the hand. This comparison can be made with the radial nerve by stimulating the median nerve at the wrist and the dorsal radial cutaneous nerve also at the wrist, and recording from a single site, that is from the thumb. Comparison can also be made with ulnar nerve conduction. Comparison between the median and ulnar nerve conductions can be made using two different recording points, as long as we keep an equal distance between the cathodes and the recording electrodes in both tests. This can be done for motor conduction by recording from the abductor pollicis brevis for the median nerve and from the hypothenar region for the ulnar nerve. Two-point testing can also be used to study sensory fibers. This can be done with orthodromic palm to above the wrist recording, as you can see in this element that I have just introduced in this figure, or antidromically using, or that is stimulating the median nerve above the wrist and recording from the index finger, and the ulnar nerve also stimulated above the wrist and recording from the small finger. The ulnar median nerve comparison can also be done using a single point recording. Such studies can be done for sensory fiber testing by median and ulnar nerve stimulations above the wrist and recording from the third finger, since sensory innervation of this finger is shared by the median and the ulnar nerve in the palmar area, and by the median, ulnar, and radial nerve in the dorsal area. Single point motor ulnar and median nerves comparison can also be done. This is done by recording from the palm between the second and the third metacarpals, taking advantage of the fact that the second lumbrical is innervated by the median nerve and the palmar and dorsal interossei are innervated by the ulnar nerve. Another test that compares median and ulnar motor conduction can be obtained by recording from the thenar region, taking advantage of the ulnar nerve innervating the first dorsal interosseous, the deep head of the flexor pollicis brevis, and the adductor pollicis, and the median nerve innervating of all the other muscles in that region. So take a few seconds to look at this chart. I will talk about each of these tests individually, but I want you to have a general picture in your mind when we do so. So the answer to this question is D. Next question. A patient with a measured distal latency of 4 milliseconds for a terminal distance of 8 centimeters and forearm conduction velocity of 50 meters per second would have a calculated latency of dash milliseconds, a residual latency of dash milliseconds, and a terminal index ratio of dash A 1.6, 2.4, 0.4, B 0.4, 2.4, 1.6, C 1.6, 0.4, 2.4, D 1.6, 2.4, 1. Now back to the comparison figure. This question addresses forearm to across the risk comparison testing of the median nerve. This question includes 3 elements. The first of the 3 elements is the calculated distal latency. The calculated distal latency is the time it should take for a potential once produced at the wrist to get to the end of the nerve if the distal segment nerve conduction were to conduct as fast as the more proximal segment of the nerve, in this case the median nerve, in the forearm. The formula to calculate this value is stated in this frame. The distal distance, that is from the cathode to the E1 electrode, is divided by the forearm conduction velocity. So in this question, the distal distance is 8 centimeters and the forearm conduction is 50 meters per second. The first step in this operation is to convert centimeters to meters and to execute the operation, which yields 0.0016 seconds, corresponding to 1.6 milliseconds. Hence, where the median nerve of this patient in the distal segment to conduct as fast as the median nerve in the forearm, distal latency would have been 1.6 milliseconds. The importance of this number is that it is used to calculate other values. The second element used in this question is residual latency. The residual latency is obtained by subtracting the calculated latency from the observed latency. In this case, the observed latency was 4 milliseconds, as stated in the question, and the calculated latency was 1.6 milliseconds, as we have just determined. Thus, the residual latency in this case is 2.4 milliseconds. The normal value is less than 2.6 milliseconds. 2.6 milliseconds is the maximal time that can be allotted to nerve activation, neuromuscular transmission, normal slowing of conduction due to distal nerve tapering in the normal individual. The third element is terminal index ratio. The terminal index is calculated by dividing the calculated latency by the observed latency. So 1.6 milliseconds divided by 4 milliseconds is 0.4. A value of more than 0.3 is normal. So the answer to this question is A. Next question. Comparison techniques results that clearly agree either normal or abnormal should be adequate to electrodiagnostically confirm the presence of carpal tunnel syndrome A6, B3, C5, D4. Traditionally, the testing obtained in patients with suspected carpal tunnel syndrome is median sensory nerve distal latency. If this test is abnormal, one comparison testing is all that is needed for electrodiagnostic confirmation of carpal tunnel syndrome. If the test is normal, we would also need to perform comparison testing. If the comparison testing is normal, then we should conclude that there is no electrical evidence of carpal tunnel syndrome. If the test is abnormal, then in all likelihood we are faced with a very mild electrodiagnostic carpal tunnel syndrome. In either case, many neurologists believe that whether the first comparison test is normal or abnormal, it is appropriate to do a second comparison test to further substantiate the conclusion supported by the initial two tests previously done. So the answer to this question is A. Next question. Median motor conduction across the wrist testing is needed to determine carpal tunnel syndrome severity. A true, B false. As we previously mentioned, the presence of a normal median nerve sensory nerve distal latency and two normal comparison tests establish the absence of electrodiagnostic carpal tunnel syndrome. The presence of a normal median sensory nerve distal latency and two abnormal comparisons establish the electrical carpal tunnel syndrome is very mild. On the other hand, in the presence of an abnormal sensory nerve distal latency, the severity of carpal tunnel syndrome has a very wide range. In these cases, the determination of severity is done based on the type of abnormality present. If the median sensory nerve distal latency study revealed only slowing, a motor median nerve distal latency should be obtained. If normal, the electrodiagnostic severity is mild. If abnormal, the severity is moderate. If the abnormality present in the median sensory nerve distal latency is that it is absent, we must again rely on median muscle nerve distal latency to further determine severity. If a muscle potential is present but it is abnormal, the carpal tunnel is considered severe. If no potential is recorded, the severity is considered extreme. So, what if the sensory distal latency shows no potential and the motor nerve conduction is normal? Consider going back and testing again because of the possibility of an error. So the answer to this question is A. Next question. The use of palm median nerve comparison test help distinguish carpal tunnel syndrome from peripheral neuropathy. A true, B false. As you can see, this frame has the figure of the general comparison test for carpal tunnel syndrome. The arrow indicates to the median nerve short distance comparison between two segments, the cross the wrist to palm segment and the palm to third finger segment. This test is primarily done to distinguish carpal tunnel syndrome from peripheral neuropathy. This antidromic test is performed by placing the cathode on the median nerve 14 centimeters from E1 in the middle finger and performing a second stimulation at the palm 7 centimeters from E1 as indicated in this figure. Then the latency from the palm is subtracted from the latency obtained following wrist stimulation, the result represents the conduction across the carpal tunnel, as schematically depicted by the arrows in this frame. Both distance being equal, 7 centimeters, allows for comparison between them. So, if we find that the maximal slowing has occurred in the wrist to palm segment, the most likely cause for the slowing is carpal tunnel syndrome. If, on the other hand, the maximal slowing is in the palm to finger section, then the likely diagnosis is peripheral neuropathy. So the answer to this question is true. Next question. Median F wave are considered standard testing for complicated carpal tunnel syndrome. A true, B false. As we previously mentioned, carpal tunnel can be considered uncomplicated when no other condition is being considered, and complicated when other conditions such as radiculopathy or mononeuropathy multiplex is being considered. In the later situation, the studies recommended are a battery of standard tests. The standard test consists of a median nerve motor study to abductor pollicis brevis, including palm, wrist, and elbow stimulation, and also a median F wave. Median sensory nerve conduction studies using palm and wrist stimulation to the index finger are also considered standard. In addition to standard testing, patients with complicated carpal tunnel syndrome should have comparison testing, to which we have alluded previously, and target testing, which consists of those tests suggested by the condition being considered in the differential diagnosis. So the answer to this question is A. Next question. Conduction block can be diagnosed by comparing compound abnormal pollicis brevis amplitude following wrist and palm stimulations. A true, B false. This frame shows the electrode placement for median palm motor latency recording. And on the side, I have drawn a cartoon representing the same test and the main muscle being evaluated. As you can see, with palm stimulation, we mainly evaluate the conduction through the recurrent branch of the median nerve. The waveform I have just introduced is an example of compound muscle potential often obtained in normal individuals and in patients with primary conduction block at the carpal tunnel region. This test is difficult to perform, thus the presence of a distorted potential should make us consider the possibility of a technical error. The reason for technical errors found with palm stimulation usually are undesirable stimulation of the ulnar nerve, abnormal E1 location away from the motor point of the abductor pollicis brevis, and shock artifact contaminating the compound muscle action potential. Resolution of technical issue is often brought about by decreasing the stimulus intensity, appropriate placement of E1, and anode rotation. Following palm stimulation, we should do wrist stimulation keeping E1 at the same position as part of the standard testing for complicated carpal tunnel syndrome. I have introduced a cartoon representing wrist stimulation in this frame and the typical potential obtained after such a study. A latency of less than 4 milliseconds is considered normal in most adults. The question as to why should both tests be done can be answered with an example. Here you can see the potential produced by median nerve wrist stimulation. The low amplitude of the potential would make us conclude that we are dealing with an axonal loss neuropathy. But with palm stimulation, you can see that a large well-formed potential is present, leading to the correct conclusion that we're dealing with a conduction block. Remember that motor conduction block is defined by many neurologists as a reduction in a potential of at least 20% in the proximal motor amplitude compared with the distal motor amplitude, with a duration increase of no more than 15%. Sensory conduction block, on the other hand, is defined as a reduction of at least 50% in proximal amplitude compared with distal sensory amplitude. Duration is not taken into account to make this conclusion. So the answer to this question is A. Next question. Median motor nerve conduction can be determined for the arm segment. A true, B false. Here you see median nerve stimulation at the antecubital fossa, here above the wrist, and here at the palm. Median nerve can also be stimulated just up below the axilla and at about the axilla. As you can see, conduction through all these segments will produce a relatively stable potential. So the answer to this question is A. Next question. Median nerve F wave can be helpful in determining the cause of hand weakness. A true, B false. Notice that in this picture the cathode is proximally placed. This is in order to obtain the minimal F latency, which corresponds to the back, to the spine, and forth to the muscle conductions. The back or proximal conduction is produced by electrical stimulation at the cathode. The fourth or distal conduction is produced by activation of about 3% of the motor neurons receiving the stimulus. Tables related to distance and formulas are used to determine normalcy of the minimal F latency. So the answer to this question is A. Next question. Sensory studies are more sensitive than motor studies to diagnose carpal tunnel syndrome. A. True, B false. It is apparent from all previous questions and answers that the most sensitive test for carpal tunnel syndrome involved is achieved by testing the sensory fibers. Probably the most sensitive test to diagnose carpal tunnel syndrome is the combination of median palm sensory antidromic latency and wrist sensory antidromic latency. When these tests are combined, as you can see in this sample obtained in a patient with carpal tunnel syndrome, it provides clear evidence of the status of the median nerve in the carpal tunnel. Taking into account that the distance from the palm to finger and from wrist to palm is the same, it is clear that the wave took longer to travel through the wrist segment than to travel through the palm to finger segment. So the answer to this question is A. Next question. Meaningful comparison between median and ulnar motor nerves can be achieved by comparing conduction to a single site only. A true, B false. Now we're back to the comparison test chart or figure. Median ulnar nerve comparison testing can be done following one of two methods. One method is called the two-point method. This method refers to recording from two different sites after stimulating each nerve separately at a similar distance between E1 and the cathode. This can be done involving motor conduction, recording from the abductor pollicis brevis for the median nerve and from the hypothenar region after ulnar stimulation. I will now enlarge the view to give you a few details about this test. In this enlarged figure, you can see the site of stimulation and recordings for this test. The distance between stimulating and recording electrodes, as you can see, should be the same, preferably 8 centimeters. A difference of more than 1.8 milliseconds is definitely abnormal. A difference of more than 1.2 milliseconds is probably abnormal in this test. In addition to median to thenar and ulnar to hypothenar latency difference, which compares conduction using different recording sites, studies have been designed using a single recording site. One of these studies uses the palm as recording site following median and ulnar nerve stimulations. This test is called the median ulnar motor latency difference to intrinsics. Stimulation of the median nerve records conduction to the second lumbrical. Stimulation of the ulnar nerve records conduction through the deep branch of the ulnar nerve going to the palmar and dorsal interossei. The result of this test is considered abnormal if the difference is more than 0.5 milliseconds. In addition to palmar recording, single point recording can also be achieved by recording from the thenar region. I will use this enlarged version to describe it. Median nerve stimulation is done with the cathode 8 centimeters from E1. Ulnar nerve stimulation is done 1 centimeter proximal to the distal wrist, which corresponds to 8 centimeters to E1 in the thenar region. Ulnar stimulation records the deep head of the flexor pollicis, the adductor pollicis, and to some extent, it also records potential from the first dorsal interosseous. This test is considered abnormal if the difference is more than 1.4 milliseconds. So meaningful comparison between median and ulnar motor nerves can be achieved by comparing conduction using single site recording at the thenar region or at the palmar region, or it can also be achieved by 2-point recordings at the thenar and hypothenar region simultaneously. So the answer to this question is B. Next question. Meaningful comparison between median and ulnar sensory nerves can be achieved by dash techniques: A2, B3, C4, T5. As we have just seen, median and ulnar motor conduction comparison studies can be used as a technique for the evaluation of patients with suspected or diagnosed carpal tunnel syndrome. The story with sensory conduction evaluation is much the same. Median and ulnar sensory comparison studies can be achieved using two recording sites. For sensory conduction determination, as you can see pointed by the arrow, we can use from wrist to two palm sites, from wrist to two different fingers, and we can also make comparison using a single point recording. This is achieved by stimulating the wrist and recording from the ring finger. So the answer to this question is B. Next question. Which of the following tests records conduction of the fastest fiber? A. Ring diff. B. Palm diff. C. Median to second finger and ulnar to fifth finger test. D. All of the above. Ring diff refers to antidromic comparison to a single site, the ring finger. Sensory recording median to digit 2 and ulnar to digit 5 also test sensory antidromic conduction of the fastest cutaneous fibers. Palm diff stimulates the fibers in the palm, including those from muscle spindles, and since the conduction velocity of these fibers is the fastest, palm diff records the fastest fiber. This is so because neither the stimulating electrode, as in the case of it is with orthodromic sensory recording from the fingers, nor the recording electrode, as is the case in motor or antidromic sensory recording, restricts the nerve fibers being recorded. An example of the latter is shown in this frame. 1-point median and radial to thumb testing can be done as shown in this frame. During this test, only cutaneous sensory fibers are recorded by virtue of the position of the recording electrode, that is, by the location of E1. So the answer to this question is B. Next question. Please take a look at this frame. This study is consistent with Martin-Gruber anomaly and carpal tunnel syndrome. True or false? Take a few seconds to look at this frame before moving on to the next, if you have to. Median motor nerve conduction study in a patient with Martin-Gruber anomaly involving the adductor pollicis, the first dorsal interosseous, or both, when occurring in a patient with carpal tunnel syndrome, produces peculiar findings. These findings arise because of the fibers traveling in the median nerve proximally and crossing in the anomaly at the forearm when tested at the proximal site, that is, when the median nerve is tested at the proximal site in the antecubital region, they will contribute to the velocity and the amplitude of the potential recorded in the thinner region, but no such contribution will occur with distal median nerve stimulation. On the other hand, the terminal latency following distal median nerve stimulation will be increased, and the amplitude may also be reduced by the compression of the carpal tunnel. Antecubital median nerve stimulation will produce a potential with two peculiar morphological characteristics. The first one is a definite initial dip. This dip occurs because the fibers traveling in the median nerve towards the ulnar thinner muscles, the adductor pollicis, and to a lesser extent, the first dorsal interosseous in patients with Martin-Gruber syndrome will contribute to the potential capture at the thinner eminence, and since they bypass the carpal tunnel entrapment by crossing to the ulnar nerve at the forearm and entering the hand through the Guyon's canal, they are not slowed down by the entrapment. It is the early arrival coupled with the off-center electrode position in relation to the point of origin of these ulnar muscle potentials that is recorded as a pre-negative wave dip. The second peculiar finding is a low amplitude and increased duration potential. This phenomena is due to phase cancellation. So, a prolonged terminal latency coupled with a low amplitude potential preceded by a dip present following proximal stimulations suggests the presence of Martin-Gruber syndrome in patients with carpal tunnel syndrome. So the answer to this question is true. Next question. Please take a look at this frame and try to choose the correct answer. The question is, the speedy conduction velocity results because median to ulnar crossing fibers are very thick and well myelinated. A true, B false. I will first describe the calculation needed to determine conduction velocity by using a normal example. Let's say we are conducting a median nerve wrist and elbow motor conduction study in a normal person, and we find a terminal latency of 3 milliseconds, a proximal latency of 6.8 milliseconds, and a latency distance of 210 millimeters. I will now introduce a diagram showing these findings. Conduction velocity is a calculated value using three factors. That is, the factors that I have just listed. I will go ahead and name them again. First, terminal latency. Second, proximal latency. And third, distance between cathode use for determination of both latencies. The first step in the calculation of conduction velocity is to determine the latency difference by subtracting the terminal latency, which is 3 milliseconds, from the proximal latency, that was 6.8 milliseconds. Thus, the latency difference is 3.8 milliseconds. The second step is to calculate conduction velocity by dividing the distance between the cathodes in millimeters by the latency difference. In this case, the distance was 210 millimeters and the latency difference is 3.8. Thus, we execute the operation and get a conduction velocity of 55 meters per second as expected. Now let's see what happens when we go through the same process in the presence of Martin-Gruber anomaly. As you can see, the potential recorded in the thinner eminence following proximal medial nerve stimulation includes the fields generated by the activity of the radial innervated ulnar muscles. Let's say that in this patient the terminal latency is 7 milliseconds, the proximal latency is 10.8 milliseconds, and the distance between cathodes, as in the prior example, is 210 millimeters. In such case, we begin by subtracting the terminal latency, which is 7 milliseconds, from the proximal latency, which is 10.8 milliseconds. So the latency difference is 2.8 milliseconds. So conduction velocity, as you know, is calculated in the customary fashion by dividing the distance in millimeter between the cathodes by the latency difference. So 210 is divided by 2.8, giving a velocity of about 75 meters per second. This is a falsely fast conduction. It results from the method of calculation used and not from the fibers conducting any faster than they would otherwise do. That is, it is not an increase in the thickness or myelination of the fibers going through the Martin-Gruber anomaly that contributes to the speed of conduction in these cases. So the answer to this question is B. Next question. Combined sensory index includes median to index and ulnar to little finger conduction comparison. A true, B false. The combined sensory index consists of 3 tests. I brought back the comparison test chart so we can have a good perspective of the test used for the combined sensory index determination. One of the tests used to calculate the combined sensory index is median ulnar wrist to ring finger comparison test. The second one is median radial wrist to thumb test. As you can see, in both of these tests, 1 point recording is being done. The third one, that is the third test that we do as part of the combined index, is the median and ulnar palm to wrist test. Now that we have named them, I will tell you a little bit about each of them separately. The first one is the median and ulnar wrist to ring finger test. In this test, the recording device is placed in the ring finger. The stimulating device for median nerve testing is placed proximal to the distal wrist crease, and the sensory action potential is thus recorded. Now the same thing is done with the ulnar recording, as you can see. The peak latencies of the two potentials is determined, and the time difference between the two measured. In a normal control, the difference does not exceed 0.4 milliseconds. This is called the ring diff test. The second test is the median and radial wrist to thumb test. In this test, we stimulate the median nerve above the wrist while recording from the thumb, which often produces a small but well-defined potential, as you can see in this frame. Then we stimulate the superficial radial nerve. We do this by placing the stimulating electrode above the superficial radial nerve in the dorsal aspect of the forearm, just above the wrist. The potential often obtained looks rather similar to the prior potential. The difference in their peak latency in this case was 0.1 millisecond. A normal value is when the difference is less than 0.6 milliseconds. Therefore, in this case, the results was normal. This test is colloquially called the thumb diff test. The third test is the median and ulnar palm to wrist test. This test is different because of the short distance between the stimulating cathode and E1. It tests orthodromic conduction, and the test fibers include the rapidly conducting muscle spindle fibers. Stimulation is done at the palm between the second and the third metacarpals, with E1 placed proximally above the wrist. The latency to this potential is short. Next, we stimulate the palm between the fourth and the fifth metacarpal. E1 is kept above the wrist, but now on the ulnar side at the same distance. It is very important that we keep the same distance that we did when we stimulated and recorded from the median nerve. The latency of both nerves in normal circumstances is short. The difference in this example was minus 0.1 milliseconds. The minus sign indicates that ulnar latency was longer than median latency. This is a normal result, the normal being for median conduction to be 0.3 milliseconds or less longer than ulnar conduction. This test is called the palm diff. So the answer to this question is B. Next question. Normal combined sensory index is 1 or less than 1. A true, B false. As we have just heard, the combined sensory index consists of 3 tests. These tests are often conducted simultaneously. Here you can see an example of the median and ulnar test to ring finger testing. The result in this case was 0.1 millisecond difference. The result of the median and radial wrist to thumb test was 0.2 millisecond difference. And the third test, the median and ulnar palmar to wrist test, showed a difference of 0.1 milliseconds. The result of the combined sensory index, which corresponds to the adding the difference in each of the cases, that is, in each of the 3 tests that we perform, in this case was 0.4. As you know, a result of this index of less than 1 is normal. So the answer to this question is A. Next question. Please take a look at this screen and try to find the correct answer. The question is, based on the first study, the diagnosis of carpal tunnel syndrome can be confirmed. A. True. B. False. We have already established that a combined sensory index of 1 or more than 1 is abnormal. Thus, in this case, the first test, the median and ulnar wrist to ring finger was more than we would consider normal. Thus, if the second result supports the first, there is no need to do a third component of the combined sensory index. But it is important that we always do 2 tests, not only 1, to make sure that we don't overdiagnose carpal tunnel syndrome. I will expand on this concept in the next few frames. As we previously mentioned, the usual best practice is that when the initial test is consistent with carpal tunnel syndrome, a second test should be used to confirm the presence of an electrical abnormality. So in this case, a third test could be avoided and the diagnosis can be confirmed, but the second test should be done. So the answer to this question is false. Next question. Inching can be used to precisely localize the site of injury in the carpal tunnel. A. True. B. False. I will first show you a normal inching study. This figure shows the location of the stimulator for performing an inching test. As you can see, the stimulating site is placed at 1 centimeter intervals towards the recording electrode at the index finger. In this case, 1 centimeter proximal to the distal wrist crest is labeled -1. The potential produced by such stimulation is shown on the side appropriately labeled. Now the zero potential corresponding to the cathode at the proximal wrist site is shown. Now 1 centimeter above the distal wrist crest. Now 2. Now 3. Now 4. Now 5. And now 6 centimeters from point 0. These potentials can be grouped together, as I have just done, to see their contour and timing. In this case, as you can see, contour and timing is similar. Now I will show you an abnormal test. We will start with the same arrangement, but I want you to consider, as the results of the testing is given to you, about localization. Stimulation at the level of -1 produces a potential that looks delayed, but in reality cannot be judged as such, because at this point there is no control. Now we stimulate at level 0. The potential looks much the same. Now at level 1, you can see that the potential still looks delayed. Stimulation with the cathode at level 2, indicated by the aqua color number, produces a potential with a different shape and different latency. Stimulation at level 3 produces a potential similar to the previous one. Stimulations at level 4 shows a similar potential. Same at level 5 and at level 6. If we now put all of the potentials together, as we did before, we find two sets. The one after stimulation of site 2, which have occurred earlier, and the second one prior to stimulation at level 2 that have occurred later. Hence, a change have occurred between +1 and +2, which corresponds to the outlet of the carpal tunnel canal, the most frequent location of entrapment. And so, in this case, the entrapment occurred at that site. So the answer to this question is A. Next question. There is an undeniable association between obesity and carpal tunnel syndrome. A true, B false. In the pediatric age group, carpal tunnel syndrome is seen in patients with mucopolysaccharidosis, to the point that some advocate annual testing starting as early as 3 years of age to all patients with these conditions. Risk factors for carpal tunnel syndrome are linked to certain professions. These professions make often use of the wrist, and they consist of essentially mechanical activity, as you can see in this frame. Some other diseases are also linked to carpal tunnel syndrome. Obesity is linked to carpal tunnel syndrome in the book I listed and show you in this frame, but this is not considered to be the case by other authors. In the monogram I have now introduced, the title is from the Society of Electrodiagnostic Medicine, and they insist that although there is a strong association between obesity and median mononeuropathy at the wrist, there's no association between obesity and carpal tunnel syndrome. So the answer to this question is B. Next question. In a patient with carpal tunnel syndrome but no clinical suspicion of radiculopathy, proximal median neuropathy, or polyneuropathy, EMG is indicated if A. Abductor pollicis brevis weakness is present, B. Thenar eminence is atrophic, C. Median compound muscle action potential show reduced amplitude, D. All of the above. EMG is a painful test to be avoided whenever possible. Two orthopedic societies have provided guidelines on the treatment of carpal tunnel syndrome. One of the criteria for surgery is based on the presence of median nerve denervation. The diagnosis of median nerve denervation, that axon loss has occurred, can be made based on median nerve conduction studies showing low amplitude or absence of potential following sensory nerve, mixed nerve, or compound muscle action potentials. But the most sensitive test for denervation is EMG. So many neurologists recommend to do EMG when weakness of the median nerve innervated muscle is clinically detected. That is, if the weakness is present, if atrophy in the thenar muscle is present. For the purpose of documentation, EMG is recommended in these two cases. And if there's a reduced amplitude of median compound muscle action potential is present. Again, for the purpose of documentation. The muscles to be tested are the one most affected, usually the abductor pollicis brevis or the opponent pollicis. Signs of denervations are fibrillations, large motor unit potentials, and excessive polyphasic motor unit potentials. So the answer to this question is D. Thank you very much for your attention.